Welcome to the deep dive. Today, we're tackling something, well, pretty common, nausea and vomiting.
Yeah, it's something most people unfortunately experience at some point.
Exactly. And you shared a chapter that really dug into the meds for it, antiemetics. Turns out it's way more complicated than just feeling queasy.
It really is.
Mm-hmm.
And we also have that audio recording snippet touching on related GI issues and, some common drugs too. It helps tie things together.
Right. So our mission today is to unpack these antiemetics. What are they? How do they actually work? And maybe uncover some, surprising facts.
Sounds good.
Ugh.
Because feeling sick, it's horrible, but vomiting itself is actually a pretty complex reflex.
Yeah, the chapter mentions sometimes inducing it used to be thought helpful, like for poisoning, though less so now at home.
Right, exactly. That audio point about not inducing vomiting at home for poisoning now and calling poison control instead, that's a big shift. Usually vomiting isn't helpful and can even be bad, like causing dehydration.
That's where the antiemetics step in.
Precisely.
So the chapter clearly distinguishes emetics, the ones that make you vomit, which we now know aren't for home use, from antiemetics, our focus today.
And antiemetics work to decrease or prevent nausea and vomiting.
And one of the first things it notes is they can work centrally in the brain or locally, like right in the gut.
Yeah, and their effectiveness can vary quite a bit.
Let's dig into that central versus local thing first. How does that work?
Okay, so think of centrally acting ones like intercepting the message in the brain's control room. They block signals up there.
Ah, okay. Blocking the feel sick command.
Pretty much. Whereas local ones work directly on the stomach or intestines, maybe soothing irritation or helping things move along faster down there.
Got it. Calming the source directly. Makes sense. So the chapter then goes into the main groups acting centrally. This is where it gets interesting. First up, phenothiazines. And get this, some are also used for psychiatric conditions.
Right, like chlorpromazine, perfenazine.
Prochlorperazine, promethazine too.
Exactly. And they target that spot in the brainstem, the
Wow.
CTZ.
The chemoreceptor trigger zone in the medulla.
Yeah, and they mainly block dopamine signals there. Promethazine also hits histamine receptors.
So blocking dopamine stops the vomit signal.
Largely, yes. That's a key pathway for nausea in the CTZ. They tend to work fast, too.
Okay. And the chapter says liver metabolism, urine excretion. Oh, and they cross the placenta and get into breast milk.
That's a really important point. We'll definitely circle back to that when we talk about, different life stages in pregnancy.
For sure. And there are some serious contraindications listed too: coma, CNS depression, brain injury.
Severe blood pressure issues, high or low, severe liver dysfunction. They definitely don't use them then.
And cautions for kidney problems, moderate liver issues, ulcers, pregnancy, lactation, and promethazine specifically in kids.
Yeah, lots to consider. And the side effects list is, well, it's long. Drowsiness, dizziness, weakness, tremors, headache.
Hypotension, arrhythmias, autonomic effects, even those extrapyramidal symptoms.
What are those exactly? Like movement issues. Yeah, things like muscle stiffness, spasms, restlessness, kind of Parkinson's-like effects sometimes. Also endocrine effects, photosensitivity.
Wow. And a big one, interaction with other CNS depressants, like alcohol.
Absolutely critical. Mixing them can really knock you out, much more than either one alone.
Okay, so the prototype drug here is prochlorperazine, used for severe nausea, even post-op.
Right, same basic idea. CNS depression, dopamine blocking.
Works pretty quick, especially injected. Liver metabolism, urine excretion, like the others. Side effects mentioned specifically for this one: drowsiness, sure, but also dystonia, those muscle spasms.
Yes, and photophobia, blurred vision.
And that weird but harmless pinkish urine color. Plus the extrapyramidal stuff, low blood pressure, and something called neuroleptic malignant syndrome.
That's a rare but very serious reaction. Fever, muscle rigidity, confusion. It's a medical emergency.
Yikes. Okay, so similar class but slightly different profiles.
Exactly.
Moving on then. Non-phenothiazines. Basically just one main drug here, metoclopramide.
Ah, yes. Reglan is a common brand name.
This one's interesting. It blocks dopamine, like the others.
But it also does something else.
Yeah.
It makes GI cells more sensitive to acetylcholine.
Which does what?
It increases GI activity, gets the stomach and intestines moving, so it helps empty the stomach faster.
Okay, like a double action. And the chapter says it's discussed more elsewhere, but it came up in that audio recording too, didn't it?
Yes.
Yeah.
Very important context.
So looking at the prototype details for metoclopramide, uses include GERD symptoms, chemonausea, post-op nausea, diabetic gastroparesis.
Right. Situations where you want to encourage gut motility as well as block nausea signals.
Works fairly quickly, liver metabolism, urine excretion again, side effects, drowsiness, fatigue, restlessness, those extrapyramidal symptoms pop up again.
Parkinson-like reactions, even seizures, potentially.
Yeah.
And GI stuff like nausea, diarrhea.
But here's the connection to the audio. It specifically mentions metoclopramide can be associated with tardive dyskinesia.
That's the one. The audio really highlighted that risk. Tardive dyskinesia involves those involuntary repetitive movements, often facial tics, lip smacking.
And it can be long-term, right? Even after stopping the drug.
It can be, yes. Which is why it's such a significant potential side effect to be aware of. That audio point was crucial.
Definitely underscores knowing the risks of your meds. Okay, next big group, serotonin receptor blockers. The 5-HT3 antagonists.
Right, like granisetron, ondansetron, polonicitron too.
Ondansetron is probably the one most people have heard of, maybe as Zofran.
Very likely, yes. It's used a lot.
So these block serotonin receptors, both in the CTZ and locally in the gut as well.
Correct. Serotonin is a major player in nausea, especially from chemo and radiation and postoperatively. Blocking it is very effective there.
Game-changer drugs, the chapter implies.
They really were, particularly for improving quality of life during cancer treatment. They absorbed rapidly, liver metabolism, urine excretion, the usual pattern for many.
Okay. Contraindications, allergy, obviously. And ondansetron specifically shouldn't be used with long QT syndrome.
That's a key heart rhythm issue. Ondansetron can potentially prolong the QT interval, which can be dangerous in susceptible people.
Got it. Cautions also for post-abdominal surgery, pregnancy lactation, and ondansetron, again, with electrolyte problems.
Electrolyte imbalances can also increase the risk of heart rhythm issues, so it's related.
Makes sense. Common side effects listed. Headache, dizziness, myalgia, that's muscle pain.
Yep, muscle aches. Also injection site pain if given that way, rash, constipation or diarrhea, sometimes hypotension or urinary retention.
And interactions to watch for other serotonergic meds.
Right, risk of serotonin syndrome if combined with things like certain antidepressants.
And with ondansetron, other drugs that prolong that QT interval.
Definitely need to check for those interactions.
So the prototype, ondansetron, Zofran, use chemo, radiation, post-op nausea vomiting, action. Blocking 5-HT3 receptors peripherally and centrally. Pharmacokinetics, pretty quick onset, especially IV. Liver metabolism, urine excretion. Half-life around 3.5 to 6 hours.
Relatively short-acting compared to some others.
And key adverse effects again. Headache, dizziness, drowsiness, myalgia, urinary retention, constipation, diarrhea, injection site pain. Seems fairly typical for the class.
Yes, those are the most common things people might experience.
Okay, next up. The newest class. Substance P-neurokinin 1 receptor antagonists.
Right, aprepitant, fosaprepitant, rolapitant. These are newer players.
They block different CNS receptors involved in nausea vomiting, targeting substance P and neurokinin 1.
Exactly. It's another pathway, particularly important for delayed nausea after chemo, which can happen days later.
Ah, okay, so they might be used alongside other antiemetics.
Often, yes. Especially for highly immunogenic chemotherapy regimens.
Indications vary a bit between them. Liver metabolism, again, excretion in urine and feces this time. And they also cross placenta breast milk.
Similar precautions there regarding pregnancy and lactation. Allergy is the main contraindication.
Side effects seem a bit different. GI issues like diarrhea, constipation, gastritis, nausea, anorexia.
Also headache, fatigue,
Yeah.
and potentially effects on blood counts, neutropenia, anemia, leukopenia.
Okay, so monitoring blood work might be needed?
Potentially,
Yeah.
yes. And important drug interactions listed. Temazide, warfarin,
Yeah.
hormonal contraceptives too. Yes, they can potentially make birth control pills less effective, which is a really important interaction to counsel patients about. And the warfarin interaction needs close monitoring of blood clotting.
Wow, okay. The prototype here is aprepitant, used with other agents for acute and delayed nausea vomiting from highly immunogenic chemo.
Right, hitting both phases.
Action. Selective block of those substance PNK1 receptors in the CNS kinetics. Decent onset oral or IV liver metabolism.
Yeah.
Primarily excreted via metabolism itself. Interesting.
Yeah, it's broken down extensively by the liver.
Okay.
And it has a longer half-life, 9 to 13 hours.
Which helps with that delayed nausea, right?
Exactly. It sticks around longer.
Key adverse effects: anorexia, fatigue, constipation, diarrhea, liver enzyme elevations, dehydration.
So managing hydration and monitoring liver function can be important with aprepitant.
Okay, quite a complex picture for these newer agents. Then finally, there's a miscellaneous group. Kind of a catch-all.
Bit of a mixed bag, yeah. Different mechanisms here.
Like dexamethasone, a steroid. Mechanism unclear for nausea, but it's used.
Often in combination, particularly for chemo-induced nausea.
Then antihistamines, dimenhydrinate, hydroxyzine, meclizine. They block histamine and muscarinic receptors.
And meclizine, as the chapter notes and as came up in that quiz question from the audio source, is particularly good for vestibular issues, inner ear problems, motion sickness.
Right, I remember that connection. Then we have dronabinol and nabilone cannabinoids.
Related to marijuana compounds, yes. Used for chemo nausea.
And the audio mentioned this too, helping cancer patients with nausea and appetite, similar to medical marijuana.
Exactly. And the caution about driving is important with these due to potential drowsiness or altered perception.
Good point. Then scopolamine, the anticholinergic patch for motion sickness.
Yeah, behind the ear. Very common for cruises or post-op. The audio also mentioned its use in hospice care, perhaps for managing secretions or nausea.
Interesting. And lastly, trimethobenzamide, thought to decrease signals in the vomiting center itself.
So another way to dampen down that reflex. Yeah. This group really shows there isn't just one way to tackle nausea.
Definitely not. Okay, the chapter also talks about use across the lifespan. For kids, the big message, echoing the audio, is called poison control. If you suspect poisoning, don't induce vomiting.
Crucial advice. And use animatics consciously in kids. They can be more sensitive to CNS effects. Dehydration is a bigger risk.
Yeah, treating the cause is often preferred. And careful use after anesthesia.
Right. Managing fluids and electrolytes is key for children with vomiting.
For adults, common uses are post-op, chemo, and be aware of CNS effects impacting mobility, like dizziness.
Simple precautions like getting up slowly can help.
Pregnancy and breastfeeding. Safety often isn't clearly established for many of these.
It's always a risk versus benefit calculation. Use only if clearly needed, and be aware they might get into breast milk or effect supply.
Always a tough call. And older adults. Higher risk for side effects.
Definitely. Sedation, confusion, dizziness, fluid shifts, cardiovascular effects. They're more vulnerable.
Might need safety measures like fall precautions, and they're more likely to have kidney or liver issues.
Which often means lower doses are needed and closer monitoring because they might not clear the drug as efficiently.
Makes sense. So, wrapping back to that audio recording's key takeaways. Number 1, no more syrup of Ipecac or inducing vomiting at home for poisoning. Call poison control.
Absolutely, the standard advice now.
And second, know your medications and side effects. The tardive dyskinesia risk with metoclopramide was a stark example.
Really highlights the need for awareness and monitoring.
And the audio also mentioned correct use of other meds, like laxatives not for bowel obstruction or ongoing diarrhea, just using things appropriately.
Using medications correctly and for the right reasons is fundamental.
So, to sum up this deep dive, we've really covered a lot of ground on antiemetics, different types, how they target the body.
Yeah, looking at how they interfere with those nausea and vomiting signals in the brain or the gut.
And we touched on important considerations for different people, different ages. It's pretty fascinating how these drugs interact with our nervous system or digestive system.
It really is.
Yeah.
And how, a drug for one thing, like psychiatric conditions, can end up helping your stomach. It shows how interconnected everything is.
Yeah. And that insight about cannabinoids, like marijuana derivatives, being legitimate treatments for chemonausea was surprising too, shows how things evolve.
And that shift away from home emetics really drives home how medical understanding changes over time based on evidence.
Absolutely. So for you, the listener, maybe you deal with motion sickness sometimes, or you're helping someone through chemo, or you're just curious.
Hopefully this gives you a better handle on these medications.
Yeah, maybe helps you have more informed chats with doctors.
And remembering that point from the audio, knowing when not to induce vomiting is just as vital as knowing how to treat nausea.
Well said. It's complex biology we're trying to influence.
For sure. And we've really only scratched the surface here. There are so many more details about specific uses, guidelines.
Oh, definitely. You could dive much deeper into the molecular mechanisms or specific clinical protocols.
So maybe something to think about until next time. What other questions do you have about how our bodies handle feeling sick and how we try to step in? Definitely food for thought.